Hi everybody and welcome to our module on sodium disorders. Sodium disorders are different from other electrolyte disorders because in general these are problems that have to do with water and not sodium. For example, when patients are hyponatremic, it means there is too much water relative to sodium, and when patients are hypernatremic, it means there is too little water in the plasma. As we will see in this module, the predominant symptoms in both hypo and hypernatremia tend to be those that involve the brain. When there's low sodium, this leads to a low plasma osmotic pressure because sodium is a very important osmole in the plasma. This means that fluid will leave the plasma and go into tissues and the brain will swell, and that leads to many of the symptoms of hyponatremia. Conversely, when there is high sodium in hypernatremia, there is high plasma osmotic pressure. This leads to fluid being drawn out of tissues and the brain shrinks, and that also leads to many of the symptoms of hypernatremia. So we'll begin by talking about hyponatremia or low plasma sodium. This tends to be more confusing for students than hypernatremia. Hyponatremia has a diverse set of potential causes and a number of tests that are typically done. So first of all, let's talk about the symptoms. And as I said on the last slide, when you have hyponatremia, fluid will move into tissues and the brain will swell, and that leads to the symptoms like malaise, stupor, and coma, and nausea as well. There are three key diagnostic tests that are important for all sodium disorders, but especially hyponatremia, and we're going to talk about all of these in the next few slides. The first one is the plasma osmolality, the second is the urinary sodium level, and the third is the urinary osmolality. The plasma osmolality is a measurement of the amount of osmotically active solutes that is present in the plasma, and one of the most important osmotically active solutes is sodium. When the sodium level is low, the osmolality should also be low. That's because sodium is a key contributor to the osmolality. So you can always remember that osmolality should be low in hyponatremia, and these two words rhyme, and that always makes it easy to remember. And the first step in evaluating a patient with hyponatremia is to make sure that the plasma osmolality is low, as it should be. You can calculate the serum or the plasma osmolality using the equation I've shown on the screen. It's equal to 2 times the sodium concentration plus the glucose concentration divided by 18 plus the BUN divided by 2.8. And the normal value is 285 in the range of 275 to 295. Now, a couple of important things about this equation. Notice that sodium is the most important driver of the serum osmolality. A rise in the sodium level by 5 or 10% will create a significant increase in the serum osmolality. On the other hand, the glucose concentration is divided by 18 and the BUN divided by 2.8, so changes in those values have a lesser effect on the serum osmolality. I also want to point out that you'll notice that albumin is not in the equation for serum osmolality. That's because albumin is a very minor contributor to the plasma osmolality. Where albumin is much more important is inside the capillaries because it cannot cross the capillary membranes. In some of the cardiology modules, I talked about oncotic pressure, which is the pressure created by proteins like albumin, and they are very important in the capillaries in opposing hydrostatic pressure, but they don't play a major role in determining the serum osmolality, as you can see from this equation. So like I told you before, in a patient who is hyponatremic, you should have a low plasma osmolality. However, there are a couple of situations where you can have hyponatremia with a high plasma osmolality. Let's talk about what those are. So this can occur in hyperglycemia or in patients who have received the osmotic diuretic mannitol. Both glucose and mannitol are a powerful osmole, so they can raise the plasma osmolality. When they do this, they will draw water out of cells and dilute the sodium levels so that you will develop hyponatremia. And these are the two circumstances you should be aware of where you can develop hyponatremia with a high plasma osmolality. There are a couple of situations where you can develop hyponatremia with a normal plasma osmolality. This occurs when there are substances in the plasma that interfere with sodium measurement in the laboratory. In other words, this is not true hyponatremia. It's an artifact created by certain substances in the plasma. This can occur when lipid levels are very high. It can also occur when there are very high protein levels in the plasma, as you can get in patients who have multiple myeloma. This is often called pseudo-hyponatremia because it's an artifact in the measurement of the sodium level. So as I told you previously, the first step in evaluation of hyponatremia due to unknown cause is to check the plasma osmolality. If it is high, there is some osmole in the plasma that is pulling water out of cells and diluting the sodium level, and that can be in the settings of high glucose level or in a patient who has received mannitol. If the plasma osmolality is normal, then there's something in the plasma that's interfering with the measurement of the sodium level, and that could be lipids or proteins. Usually, however, it's going to be low, and what we're going to talk about in the rest of this module is the further workup that you do when the patient has low sodium level and a low plasma osmolality. So now let's talk about the other tests that are useful in hyponatremia. The second one is the urinary sodium level. Usually the urinary sodium level is greater than 20 milliequivalents per liter. However, in actuality, there is no normal urinary sodium level, and that's because this level varies with dietary sodium and free water in the urine. Remember that all the sodium you consume in your diet in a day must be excreted. So if you consume very little, you can have a low urinary sodium. If you consume lots of salt, you can have a high sodium. In addition, the amount of free water that you consume every day must be excreted, and this can also alter the urinary sodium level. However, this test is important in working up hyponatremia because a low value suggests either low sodium intake or excess free water, as we will talk about in the next few slides. And then the final test that's helpful in evaluating hyponatremia is called the urinary osmolality. We talked before about measuring the osmolality of plasma. Now we're going to talk about performing that measurement on the urine. So this is a measurement of the concentration of all osmoles in the urine, substances like sodium and chloride and potassium and urea. It's a very helpful test in hyponatremia because it varies with water ingestion and also urinary concentration. So for example, when the urinary osmolality is low, this means that the kidneys are excreting a very dilute urine. There's lots of free water in the urine, and that can be helpful in determining the cause of hyponatremia. When there's a high urinary osmolality, this means the urine is very concentrated, it's got relatively little free water, and the body is holding on to fluid and not excreting it in the kidneys. So now we've talked about the three clinical tests that are helpful in working up hyponatremia. We talked about plasma osmolality, urinary sodium, and urinary osmolality. But what you need to understand is what's controlling the results you get on those three tests is the level of antidiuretic hormone, which we don't measure directly, but it is working behind the scenes and it is determining the osmolality that you get in the urine and in the plasma, as well as the sodium level in the urine. As you probably know, antidiuretic hormone is often called ADH. It's also sometimes called vasopressin. The osmolality of the serum is sensed by the hypothalamus, and then ADH is released by the posterior pituitary gland in order to manipulate the plasma osmolality. When ADH is released, it leads to free water resorption by the kidneys, and this can affect the plasma osmolality. Shown on this slide are two flow diagrams to help you understand how the body responds to water intake to maintain normal sodium levels and normal plasma osmolality. If you consume excess water, there is a fall in the plasma osmolality. The posterior pituitary will respond by decreasing the amount of ADH released. This will lead to less water resorption by the kidneys and more water excretion by the kidneys, and that will dilute the urine and decrease the urinary osmolality. And note that I've bolded the change in the ADH level and the change in the urinary osmolality. These are the types of things they like to ask you on your exams. On the other hand, if you restrict the amount of water that you consume, this will raise the plasma osmolality, and the posterior pituitary will respond by increasing the amount of ADH released. This will lead to increased water resorption by the kidneys and less water excretion that will concentrate the urine and raise the urinary osmolality. A key point about ADH that you need to appreciate is that any cause of high ADH can lead to hyponatremia. Remember that ADH controls the serum sodium level and the plasma osmolality. So if ADH is always high, then sodium is no longer being controlled by ADH. When your ADH level is always high, it means that your sodium level is going to be determined by the amount of free water you take in, and most of us take in more free water than we need. This means that when you increase your intake, you can dilute your plasma and become hyponatremic. And as we will see, there are a number of clinical scenarios where the ADH level is always high, and these very easily lead to hyponatremia. Just a couple of general points, and then we'll get into specific causes of hyponatremia. In the setting of hyponatremia, if the body is responding appropriately, the urine should be diluted. The kidneys should be excreting free water, and there should be more free water than solutes in the urine, thus the urine should be dilute. This means that the urine osmolality should be low, and in addition, you may see a low urinary sodium. However, remember that the urinary sodium varies to some degree with the dietary intake, so it's not as reliable a marker as the low urinary osmolality. What this means is if the urine is diluted in the setting of hyponatremia, then the kidneys are responding appropriately. It means the ADH level is low, as it should be, and the cause of the hyponatremia must lie outside the kidneys. And we will see that there are a couple of reasons why you can get hyponatremia even if the kidneys are responding appropriately. On the other hand, if the urine is not diluted, it means the kidneys are not responding appropriately. Either there is too much ADH for some reason, or drugs or pathology are interfering with the kidney function. So these two principles are very important. They can help you understand all the causes of hyponatremia that we'll talk about on the next few slides. Now let's talk about specific causes of hyponatremia. If you look up the causes of hyponatremia, you will find a very long list. So I've always found it helpful to group them into categories. The first category is heart failure and cirrhosis. The second is when the kidneys are ineffective. The third group of causes are those that lead to high ADH levels. And finally, there's a special group which includes psychogenic polydipsia and dietary causes. The first two causes of hyponatremia are heart failure and cirrhosis. Now, in both of these disorders, patients are swollen. They have too much total body water. As you may know, in heart failure, patients can have lower extremity edema and swollen neck veins and pulmonary edema. In cirrhosis, patients can have ascites and lower extremity edema as well. So in both of these conditions, there are clinical signs of hypervolemia. However, what is happening inside the vascular space is that the body is perceiving hypovolemia. So there's a disconnect. There's real actual hypervolemia, but the body is perceiving hypovolemia. The reasons are a little bit different in heart failure and cirrhosis. In heart failure, this happens because there's a decrease in the cardiac output. In cirrhosis, this happens because of low vascular resistance and vasodilation. But in both conditions, the body thinks there's hypovolemia, even though there is actually hypervolemia. When the body perceives hypovolemia, ADH will be released. So ADH levels become high. This is called the non-osmotic release of ADH. I talk about this in the video on nephron physiology, but normally ADH levels go up and down based on the serum osmolarity. However, ADH levels will also go up when the body perceives hypovolemia to a significant degree. This is a life-saving mechanism. It's called the non-osmotic release of ADH, and it occurs only when the body perceives low intravascular volume, and that happens in heart failure and cirrhosis. So because ADH levels are going to always be high in both of these conditions, it's very easy to develop hyponatremia. If a patient just consumes a little bit too much water, the plasma sodium will become diluted and hyponatremia will occur. And importantly, if you look at the urine, it will not be diluted. The urinary osmolarity will be high, and that's because there's lots of ADH around, all being triggered by the non-osmotic release of ADH from the pituitary gland as a result of perceived hypovolemia, even though there is actual hypervolemia. Somewhat confusing, but think about it for a minute until you get this straight in your head. The second setting where hyponatremia can occur is when the kidneys are ineffective, and this can be seen in advanced renal failure patients. When there is advanced renal failure, the kidneys cannot excrete free water normally. This means that the urine cannot be diluted. Therefore, the minimum urinary osmolarity that the kidneys can produce will rise even in the setting of very low ADH. When ADH levels are low, normal kidneys will produce a very dilute urine with a urinary osmolarity that is less than 100. However, in patients with advanced renal failure, the minimum urinary osmolarity can rise to the 200 to 250 range, even in the setting of very low ADH. And a key point here is that high urinary osmolarity in the setting of hyponatremia indicates an abnormal response to the low sodium levels, and that means there is a problem with the kidneys. And then finally, you might think that if the kidneys cannot excrete free water, the patient would have signs of hypervolemia like lower extremity edema and elevated jugular venous pressure. However, it turns out that in clinical practice, hypervolemia is not a reliable sign in the setting of advanced renal failure, and patients can develop hyponatremia even when they appear euvolemic on clinical exam. Another circumstance in which ineffective kidneys can lead to hyponatremia occurs when drugs are administered that interfere with renal function. This can occur in patients taking diuretics. As you may know, diuretics cause sodium and water loss, and therefore they can disrupt sodium and water balance and lead to hyponatremia. The classic type of diuretic to do this are the thiazides. They are famous for causing hyponatremia, and we'll talk about why that is the case in a minute. However, you can also develop hyponatremia after administration of a loop diuretic. One thing to be aware of is that in patients who develop hyponatremia from diuretic therapy, the urinary findings like the urinary sodium and osmolality are highly variable. There are a couple of reasons for this. First of all, the drugs promote sodium and water excretion. Secondarily, they cause patients to become dehydrated, and this stimulates ADH release. And then finally, the amount of water and sodium in the urine vary by the dose of the drug and the dietary intake. So for all of these reasons, the urinary findings are highly